Greetings and welcome to our Clinician and Patient Education Series, or CAPES. This series is being made possible by an educational grant from Pfizer and represents a collaboration between 4 different organizations, all dedicated to improving outcomes in spondyloarthritis and psoriasis. This includes Spartan, GRAPPA, the Spondylitis Association of America, and the National Psoriasis Foundation. The title of our first module is Juvenile Spondyloarthritis and Juvenile Psoriatic Arthritis. My name is Judy Smith. I am a pediatric rheumatologist here at the University of Wisconsin in Madison. Our agenda is as follows. So after these introductions, we will hear from Wendy Olster, Asad Khan, and he will be accompanied by his mom, Amina Hamid. They will share some of their experiences being diagnosed and treated as children. And then after that, we will have an overview of juvenile spondyloarthritis from our clinician expert, Dr. Hema Srinivasalu. After her talk, we will open it up to audience questions. Please type in your questions to the chat function in your video player. It'll look like 2 bubbles. And then we will finally close this module with some announcements. So without further ado, I give you Wendy, Asad, and Amina.
Hi, I'm Wendy Olster, a PhD student at the Eindhoven University of Technology in the Netherlands. I had my first symptoms when I was 14 years old and was diagnosed with juvenile psoriatic arthritis about 2 years later.
Hello, everyone. My name is Asad Khan. I'm a junior in high school and I live in New Jersey. I had symptoms around the age of 2 and was diagnosed with juvenile spondyloarthritis at the age of 9.
Hi, I'm Amina Hamid. I'm Asad's mom. I'm an educator and homeschooling mom of 3. I have been by Asad's side since the beginning of his journey with ankylosing spondylitis and learning as I go through his experience with his symptoms, diagnosis, challenges thus far.
So Asad, you were diagnosed at a very young age. What was your disease history and diagnosis like?
Well, when I was around 2 years old, my mom noticed that I was limping when I walked. The limping would come and go. Around 4, I stopped walking suddenly due to pain in my knee. Doctors ended up finding fluid in my knee, so I was given a steroid injection to help calm things down. And then the pain had gone away until I was around 9 years old, and then it came back even stronger than before. We went to many specialists, but it took a very long time to figure out what was going on. And then finally, we went to a rheumatologist and we got tested. I was diagnosed with juvenile spondyloarthritis right after that.
It was certainly a challenging time not knowing what was causing Asad's symptoms since they started so early in life. Once he was diagnosed, we felt relief at least knowing what was going on for so long and could finally look into paths for treatment. So Wendy, how was your juvenile psoriatic arthritis finally recognized?
So for me, it also took a very long time to figure out what was going on. It started when I was 14 years old and I began having a lot of pain in my hips and my neck. I saw a pediatrician and multiple orthopedists, but none of them could really figure out what was going on. They even told me that I was too young to have a type of arthritis. And after more than 2 years of visiting hospitals, I finally visited a rheumatologist who could diagnose me with juvenile psoriatic arthritis, as the joint cartilage of my hip was broken down due to all the flares. For me, it was also a major relief, just like you, to finally get the confirmation of my diagnosis. So how was your treatment journey like?
So after my diagnosis, I was put on an anti-TNF agent. I remember the first time we had to do the injection, it took over 40 minutes because we were just not ready and it felt very scary. So from making sure we were inserting the needle into my thigh correctly, injecting it, and then keeping the needle in my leg for 15 to 20 seconds so that all the medicine was in my leg. And then we would have to take the needle out. It felt like my leg was burning the entire time the needle was in my leg and the medication was going in. But after a while, I learned how to deal with the pain. since I had to administer the injection every other week. And soon I switched over to a pen. And so we started using that instead of the injection, and it made a world of a difference to me. It's easier because I don't have to do any of the work, and it also definitely hurts a lot less. And I also had methotrexate added 2 years later as well.
So he responded well to the medication, thankfully, and has been continuing with the same treatment. He's now able to keep up with his peers and play sports, etc.
I'm very happy you responded well to the medication. My treatment journey was a bit different as I tried a lot of different treatment options before I had the right one. I started with NSAIDs and steroid injections, but they only helped short term. I also tried a lot of different types of anti-TNF drugs, but I either developed antibodies or had a lot of side effects, and it took me years to try all these options. Luckily, I am now treated with an IL-17 inhibitor, which works great. So looking back at your experience, what would be the final message you would like to share?
So for people who are newly diagnosed, the disease and treatment may seem very daunting, but there are a number of medications that have helped many patients. And in my case, the treatment has been effective for the last 7 years. And I'm hopeful that with continued research in this field, there will be advancements, many more advancements, and one day a cure.
I agree. In the beginning, it feels like a lot, and it's important to know that you're not alone in what you're experiencing. It's always okay to ask for help, and we're lucky that although sometimes it can take a long time to find the right one, there are a lot of treatment options available. Thank you for allowing us to share our stories.
Hello, I'm Hema Srinivaslu. I'm a pediatric rheumatologist at Children's National Hospital at Washington, D.C. I'm going to be talking about juvenile spondyloarthritis. The objectives of today's talk are to recognize juvenile spondyloarthritis as a disease spectrum, recognize the genetic risk factors involved, identify symptoms and appearance of disease and how these may change over time, and recognize various treatments, including role of diet and exercise. So the prototypic disease for juvenile spondyloarthritis is ankylosing spondylitis. And the origin of the word is from Greek words, where it basically means bamboo spine. And as you can see in this figure, where they tracked the spine in this gentleman over several decades, you see how the spine got its curvature. And when you look at plain radiographs, you would see that the spine consists of these individual vertebral bones are supposed to be separate. But in this disease, they fuse together with these bony fusions, and it looks and gives the appearance of a bamboo spine. But not all patients go on to develop ankylosing spondylitis. In fact, the spondyloarthritis is considered as a spectrum of diseases, with ankylosing spondylitis being at the extreme end of the spectrum. And there are several other disease phenotypes that contribute to this disease process, which include undifferentiated spondyloarthritis, psoriatic arthritis, reactive arthritis, acute anterior uveitis, arthritis with inflammatory bowel disease, and also juvenile spondyloarthritis. Now, coming to juvenile spondyloarthritis, what is this? Juvenile idiopathic arthritis is arthritis in children less than 16 years of age. And we classify them into different subtypes based on EILAR classification system. There are several kinds, such as systemic JIA, polyarticular JIA, oligoarticular JIA. The ones shaded in yellow are the ones that sort of fall in the juvenile spondyloarthritis spectrum, specifically enthesitis-related arthritis, psoriatic arthritis, undifferentiated arthritis, and also perhaps reactive arthritis, arthritis associated with IBD as well. So if patients develop spondyloarthritis features before their 16th birthday, they're considered to have juvenile spondyloarthritis. And if they have spinal features before their 16th birthday, they're classified as having juvenile ankylosing spondylitis. So this picture is another representation that shows that ankylosing spondylitis is one of the forms of spondyloarthritis, which is the most extreme form, but patients can have any of these other forms of spondyloarthritis. So also in children, they can have enthesitis-related arthritis, psoriatic arthritis, or undifferentiated arthritis. And juvenile ankylosing spondylitis is the extreme form, and not all patients go on to develop this. Now, talking about the genetic heritability, like what is the risk, the genetic risk of someone developing spondyloarthritis? HLA-B27 is one of the genes that we typically test for when we have a patient in the clinic with features suggestive of spondyloarthritis. But it only accounts for 20% of the genetic heritability of this disease. There are several other mutations that researchers are now identifying that in total account for around 7 to 8% of the heritability. And hence there's this huge green part of the pie, 72% of heritability of this disease that we just don't know. But we do know that HLA-B27 is an important risk factor in the sense the risk of developing ankylosing spondylitis is 10 to 20 times higher in patients with HLA-B27 and a family history of ankylosing spondylitis. A few words about juvenile psoriatic arthritis specifically. More than 50% of children with psoriasis, with or without psoriatic arthritis, have a family member affected with psoriasis. 50% increased risk of psoriatic arthritis is found in family members of adults with psoriatic arthritis. And the risk for both psoriasis and psoriatic arthritis is higher if the affected family members are on the paternal side of the family. So talking about the clinical presentation, like what kind of symptoms do children with juvenile spondyloarthritis present with? They can have inflammation in their joints called arthritis. And there are some joints that are more commonly involved with this disease process, like, for example, the hip joint, the knee joint, the foot, and the sacroiliac joints. And they can also have something called enthesitis, which is one of the characteristic features of spondyloarthritis. This is where there is inflammation at the sites where the tendons and ligaments get attached to the bone, like, for example, around the kneecap or at the insertion of the heel cord to the sole of the foot. And in addition to involvement of the joints and entheses, children can also have inflammation of their entire digits, which we call sausage digit. And they can have psoriatic skin patches if they have juvenile psoriatic arthritis. If they carry the HLA-B27 gene, then they can develop episodes of eye inflammation, which we call acute anterior uveitis. And if they carry the ANA marker in their blood, they can also be at higher risk of developing what we call chronic idiopathic uveitis, which is, again, an inflammatory condition of the eye. In addition, children can also have inflammation in their gut, which may or may not be symptomatic. And there are other organ systems that may also be involved, more so in adults, but rarely can be seen in children, such as the heart, lungs, and the kidneys. A few words about juvenile psoriatic arthritis specifically. It presents in two flavors. One group of children with juvenile psoriatic arthritis tend to be really young in age. They tend to be more girls, and they tend to have the ANA marker in their blood. They can have inflammation of their digits, which we call dactylitis. And they may have involvement of many joints, which we call polyarticular involvement. In comparison, older children, typically teenagers, tend to have more enthesial inflammation or enthesitis. They have inflammation of the spine, which we call axial involvement. It can affect both males and females equally, and they may not have the ANA marker in their blood. And another point to also keep in mind is the rheumatologist may give a diagnosis of psoriatic arthritis based on several other markers, and you may question asking, my child does not even have a psoriatic skin patch. One thing to remember is that in children, the arthritis may come first, and the psoriasis skin rash may lag behind by many years at times. And this is how the sausage digit looks. If you can pay attention to the second toe on the right, you see how the whole toe is swollen. And if you take a look at the picture here, you see the nail is not smooth. There are many dents or indentations, which we call pits. And this is something the rheumatology doctor will also pay attention to when you take your child for evaluation. So one tip I would like to share is if your child is big on having their nails painted, please make sure those you remove those nail painting when you take them to the rheumatologist, because they do get a lot of information from looking at the nail bed. So what happens when you take your child to the rheumatologist for further evaluation? What are the kinds of things that they may do? In addition to a detailed physical examination, looking at their enthesial sites, their joints, their nails, the rheumatologist may order a battery of lab tests, one to check what their inflammation level is in the blood is. They may want to check if the child carries the HLA-B27 gene or the ANA marker. But one thing to remember is that the labs don't make or break a diagnosis of arthritis. It's mostly based on clinical evaluation and with the, sometimes with the help of imaging studies. So in terms of imaging studies, your rheumatologist may order x-rays of involved joints to see if there are any changes of joint damage already, for example. Or they may also order a magnetic resonance imaging or MRI study to take a more deeper look at these joints. Like, for example, if we are concerned for inflammation in the sacroiliac joints in the spine, we generally do get an MRI of the sacroiliac joints to figure out what's going on, because some of these deep-seated joints, it's hard to get a good assessment just based on physical exam. The MRI study does not involve radiation, so it is safe to do. And the rheumatologist may also recommend that the child be seen by the ophthalmologist to look for any signs of inflammation, either present inflammation or signs of past inflammation in the eye. And they may refer the child to other specialists based upon the clinical scenario. Like, for example, if the child has significant limitation in the range of motion of a joint, in addition to targeting the inflammation with medications, we may recommend physical therapy for conditioning exercises and strengthening exercises. And we may refer to other specialists like the dermatologist to manage the skin patch, the psoriatic skin patch, for example, or even gastroenterology if there is concern for gut inflammation. Now, there are some challenges that we come across when we are diagnosing and managing children with juvenile spondyloarthritis. One of the challenges is diagnostic delay. The time to diagnosis of juvenile spondyloarthritis is significantly longer in children when you compare it to adults with ankylosing spondylitis. And there are several reasons for this. One reason is that several of the inflammation sites, like I mentioned, called the enthesial sites, are also the sites of mechanical issues. So they may be initially diagnosed as having mechanical problems managed with non-steroidals and physical therapy before someone makes a call that the child is complaining much more. There are many more sites involved. Perhaps this is something beyond mechanical issues. The other issue also that we deal with in children is that even when they have inflammation in the sacroiliac joints, which sits just above the buttocks, In adults, they may complain of low back pain, but children may not. In fact, there was one study that specifically looked at MRI findings in children with enthesitis-related arthritis, and there was a large percentage of children who had inflammation in the sacroiliac joints but had no back pain. This is something we recognize in clinical practice. We call it silent sacroiliitis. So if there is any clinical concern, we have a low threshold to do an MRI to figure out if there is inflammation going on there. And there is also this misconception that this is a male disease, although the one of the points of the diagnostic classification criteria of juvenile idiopathic arthritis, specifically the enthesitis-related arthritis, is that they get a point for each of those factors. And one of the points is that being a male over 6 years of age. So you can imagine how it's sort of subserving in a sense. So many females, when they complain of these sorts of aches and pains, that may not be the first thing that comes to mind to your physician. So females do tend to have a longer delay to diagnosis than males for this particular condition. And there's another aspect to juvenile spondyloarthritis. Studies looking at children with juvenile spondyloarthritis over time have noted that these children tend to have a huge component of chronic pain. And the number of enthesial inflammation sites sort of also drives this in a sense. And even when the arthritis is well controlled, these patients may still be having poor quality of life related to their pain. And majority of the patients go on to have active disease in their adulthood. So the relative likelihood of disease remission is lower for this disease subtype. In terms of treatment, one of the first things that we try are non-steroidal anti-inflammatory medications, and there are several on the market. And it's hard to tell which one your child will respond to. So the rheumatologist may have to cycle through a few before they figure out the one that works the best for your child. Glucocorticoids may be used as what we call bridge therapy, meaning when the symptoms are at its peak, we may start this medication for a short term while we wait for the other medications to sort of kick in. But we do not like to keep children on long-term corticosteroids because they have a lot of side effects. And if there are a few joints involved, say, for example, the child only has knee joint inflammation, then in addition to starting an non-steroidal anti-inflammatory medication, the rheumatologist may choose to inject steroids into that joint. That may help calm down the joint for several months to even years at some point. But if there is several joint involvement or enthesial involvement in many sites, then these medications may not be enough. And then in those scenarios, we move on to what is called disease-modifying anti-rheumatic drugs, and there are several. There's something called methotrexate, leflunomide, sulfasalazine. So the rheumatologist may discuss these treatment options with you. And in patients in whom these may not be sufficient, or say if they have involvement of the sacroiliac joints, then we do tend to move to these biologic disease-modifying drugs pretty quickly. And there are several of them again. There are several TNF inhibitors or anti-TNF agents on the market. And these have been the most studied in spondyloarthritis, and they tend to work both for arthritis and enthesitis, and also for eye inflammation. I Our armamentarium of medications to treat this condition is slowly but surely expanding. Very recently, FDA approved secukinumab for treatment for enthesitis-related arthritis and also psoriatic arthritis. And there are several other medications that we use in other forms of arthritis. And they're also used in adult spondyloarthritis that we sort of use off-label, but we know that in clinical practice, they tend to help as well. And physical therapy and occupational therapy are a necessary and important component of treatment. They are as important as any of the other medications that the child is on, especially if they have sacroiliac joint involvement, for example. It is of paramount importance for them to stretch their back and maintain that flexibility, and physical therapy plays a huge role in that. Several of these biologic medications are given in the form of subcutaneous shots, and there are some that are given as IV infusions. So this is going to be a big adjustment with a new diagnosis and with a new treatment for you and your child. So there are some tips and tricks that have been tried and tested by other parents that we would like to share. Thanks to the Arthritis Foundation, they've put together this nice list. One of the things that helps is relaxation and distraction. If you are stressed, the child is going to sense that, and they're going to be stressed, and it's not going to be a pleasant experience. So try to relax yourself and try to distract the child. This would not be the time to fight over screen time. So let them have all the screen time they want while you're trying to get the injection in. Numbing the area with ice, or sometimes your rheumatologist could also prescribe a numbing cream, topical lidocaine cream, and that needs to be applied at least like 15-20 minutes before giving the injection. And these subcutaneous shots are given either on the thigh or arm or even the belly. It really depends on what your preference is. And your rheumatologist may walk you through how to do the injection, and they may do an injection with you in the office, but subsequent ones, you learn to do it at home. Another thing that tends to help is to, once you take the medication out of the refrigerator, while you're preparing to give the shot, let that be the first thing, like taking out the medication from the refrigerator, so that while you're prepping the area, while you're numbing the area, the medication can come to room temperature, and that tends to help sting less as well. And rotate the sites. So don't aim for the left thigh every time. So 1 week it could be the left thigh, another week it could be the right thigh, or another week it could be the arm. And one of the things that we struggle with in children is that they feel like they're losing control, right? So that could be one thing that you could give them a choice. Do you want your right thigh or the left thigh injected today? So that gives them a sense of control while they truly are lacking control in a lot of aspects of their life. And another thing that may help is massaging the area post-injection. Next, I'm going to shift gears to talk about role of diet in juvenile idiopathic arthritis. I'm using the terms juvenile idiopathic arthritis and juvenile spondyloarthritis interchangeably here, but please keep in mind that whatever I share for juvenile idiopathic arthritis or JIA applies for juvenile spondyloarthritis as well. There have been no controlled studies to evaluate the effects of food in JIA. So is there a role for a specific kind of diet, and does that impact inflammation? So a diet high in carbohydrates has been shown to promote weight gain and increase inflammatory markers such as the CRP, IL-6, cholesterol, and triglyceride. A study of 21 overweight and obese young adults found that a low carbohydrate diet increased energy expenditure, decreased the C-reactive protein or CRP, and decreased their weight compared to their pre-diet baseline. And another small study looking at 22 patients with JIA evaluated effects of specific carbohydrate diet over a 4-week period. And they demonstrated significantly decreased stiffness in the morning, pain, and improvement in physical function in these children. And arthritis improved in 5 children with demonstrable decrease in the inflammation markers when they were checked in the blood. Foods that may help arthritis, some of them are things that are rich in omega-3 fatty acids, like, for example, fish. So at least 3 to 4 ounces of fish twice a week is not a bad idea, if especially if your child likes to eat fish. There are several types of fish that you could use. Extra virgin olive oil has heart-healthy fats, as well as oleocanthal, which has properties similar to that of non-steroidal anti-inflammatory drugs. There are several options there as well. Besides extra virgin olive oil, avocado and safflower oil, and also walnut oil. Cherries and other berries are a very good source of antioxidants called anthocyanins, and these have anti-inflammatory effect. Whole grains are known to reduce the inflammatory marker CRP in the blood. Good sources are oatmeal, brown rice, whole grain cereals, and also nuts. They are rich sources of protein, calcium, magnesium, zinc, vitamin E, and so on. Things that may hurt, food that may hurt, things to avoid. One would be processed sugars, because they are known to trigger inflammatory release of inflammatory messengers. So when you're looking at the food label, look for anything that ends with the OSE, like fructose, sucrose, things like that. Saturated fats also trigger inflammation, and they may worsen arthritis inflammation as well. Trans fat, like the fast food and fried products, they are known to trigger systemic inflammation as well. Refined carbohydrates, such as wheat flour products, white rice, they may also worsen inflammation. And a word about gluten and casein. These are known to affect arthritis only in someone who has a known diagnosis of celiac disease or gluten insensitivity. Next, focusing on exercise. There are no control studies to evaluate effects of exercise in JIA, but is it helpful and important to exercise when the child is suffering with JIA? Absolutely. Exercises that may help arthritis are swimming. These are very low impact activities, and yoga, tai chi, resistance training, stationary bike, and when they're able to, even walking may be good options. And when is pain from exercise okay? If the child has mild pain or discomfort before exercise that gets better after a few minutes, I think it's okay to continue. You may need to monitor or modify the exercise if there is moderate or severe pain in a specific area. You may choose to focus on a different area for a day or two. If there is consistent joint pain after exercise, switch the activity. If there is occasional moderate or severe pain the day after activity, you may have to cut down on the intensity of the exercise. But if the child experiences moderate or severe joint pain during activity, then the rule of thumb is to stop immediately and seek further guidance from your doctor. A couple word about transition. Like I mentioned, juvenile spondyloarthritis is a form of arthritis which may not go into remission as the child goes into adulthood. So having a strategy in place to transition to an adult rheumatologist is very important. And our advice is to talk frequently with your doctor about it and start early, at least a year, if not more. Although I state here that the transition age is 17 to 20, some advocates for a better transition would argue that you need to start this discussion when the child is as young as 14. At each appointment with the doctor, give a little bit of the responsibility to the child. Let the child be the one answering the doctor's questions. and talk to the child about what they know about their disease and why they're taking certain medications, what those medications are for. And when they reach closer to the age of transition, also transition some of those responsibilities to them. Let they be the ones organizing their pill boxes every Sunday. Let they be the ones calling for refills to the pharmacy when they're running out of medication. Let they be the one trying to make an appointment with their doctor. You are going to be there by their side to troubleshoot, to support, but they need to start learning how to do these things on their own. Another thing to note is if they are on subcutaneous medications, then when they feel comfortable, and this age can be different for different children, they can learn to self-administer the subcutaneous medications. And any medication changes or anything that the doctor suggests has to be a shared decision-making model between the doctor, the parents, and the child. So with that, I want to leave you some links of organizations that are doing a ton of work in providing the education and also empowering patients and families to take charge of their health and be better advocates for their health and managing their disease. I have posted their links here. Please feel free to browse through them and benefit from them. Thank you.
I would like to welcome back our speakers, Wendy, Asad, Amina, and Dr. Srinivasalu, and also invite the audience to put their questions in the chat box. I can certainly kick things off. I have a question for our patients. So some of our most effective and safe medications, unfortunately, come in the form of shots. And no one likes shots. It's especially difficult in children. So when you were going through this, what did you do in terms of mindset or physical things to make that an easier process? What kind of advice would you give families who are facing this type of therapy?
Okay, so first off, when I first got diagnosed and I was about to going to administer the injection for the first time ever, so it's definitely a very nerve-wracking experience. I remember like it was my dad who was administering it, and basically I was just crying, and it took us over 40 minutes to actually administer the injection, and it is painful. Like it felt like it was burning in my leg, and you had to keep the needle in for like 15 to 20 seconds. So the whole like concept of just keeping it in and like having like a little needle in your body, like that whole experience was just really like it made me really scared. But then once like the first time we did it, then I just realized like it's not as bad as I thought it was going to be. So as we started to do it every other week, it got better. It was easier to do. And now we also have the pen, which is just you put it on your leg and you just press it and it automatically administers the injection. And that's like, there's a lot less pain and a lot less work involved for the person who's doing it. So the pen really helped. But overall, once you start doing it a lot more, it actually becomes easier.
I totally agree with that. The first time is really scary, but then when you get used to it more, and like Asad said, then you get used to it and it feels a bit better. And also what helped for me really is those creams that helps with the itching. So that sometimes the spot where you inject really hurts after a while. So I would really recommend to talk about that if you have problems with that with your doctor.
What kind of creams were you?
For the itching, like if it's really itching after the injections, and you can put it on before, and then sometimes it also hurts less. You have different types of creams.
Okay. Amina, did you want to add anything to that?
Sure. Just with Asad, as we would, I would help him every other week. I think icing also, I would just remind him to ice his leg prior to administering. That sort of just helped also numb the area. And I would always just tell him, take a deep breath and slowly, initially my husband would help administer it. And then after that, when he switched over to the pen, he was administering it himself, but just take a deep breath, relax. And I think, as he mentioned, as time went on, it just got easier because he knew what to anticipate, and just psychologically it was easier as well.
So there's a comment here from Rachel Zymont at the Spondylitis Association of America. Thank you for sharing, Asad. And I'm sure Wendy and Amina as well. All right. I can go back and forth. Audience members, don't be shy. If you have any questions at all, we are totally at your disposal. For Dr. Srinivaslu, so this does run in families, and often as doctors, we see kids and come in who have had an HLA-B27 done because somebody in their family has this condition. If the kid feels fine, the parents are going to be concerned. What do you tell them about their chances of actually developing the condition based on having a positive HLA-B27? What does it mean, or what does it not mean?
Sure. So HLA-B27 is a gene whose prevalence depends on the race. And there is different prevalence in different populations. For example, in the Nordic population, we see very high prevalence of HLA-B27 gene, and so also in Southeast Asia, for example. In Caucasians, general population, the prevalence of this gene is around like 8 to 9%. So someone could have the HLA-B27 gene and not have spondyloarthritis. However, if there is a family history of spondyloarthritis and they also happen to carry the HLA-B27 gene, then there is a higher risk of them developing inflammation in the axial spine. So we do follow those patients more closely. And I would also like to reiterate that we can make a diagnosis of spondyloarthritis even in the absence of the HLA-B27 gene. Like I mentioned, a huge part of the heritability of this disease is still not known. So basing the diagnosis just based on the HLA-B27 would be too naive, I would say.
Okay, great. And that brings me up to a second kind of follow-up question. When you first go in to see the rheumatologist, if you don't have back involvement, can it change over time? And what do you need to be aware of looking into the future?
Great. That's a great question. Thank you for that question. So the disease can evolve over time, especially in children. They can initially present with more what we call peripheral arthritis, like, for example, arthritis in the knee or the hip or the foot, what we call the tarsal joints. And over time, there is a possibility that the patients could develop spine involvement. So if they perceive any low back pain or stiffness in the morning or pain at night, definitely do let your doctors know about it. And the doctors will also be checking your child very carefully to look for any signs of inflammation in the sacroiliac joints. They'll do certain maneuvers, and if they have clinical suspicion, they would also probably recommend an MRI of the SI joints to look for inflammation. And also, one more thing to remember is that in children, they may or may not present with low back pain all the time. So the clinicians will have a higher index of suspicion, and they would follow the patients more closely so that the inflammation in the back is not missed.
Okay. Yeah, added to that, I've also had some patients who say that their hips are involved, but it's really the low back. So sometimes it can be poorly
that's a point well
localized.
made. Yeah, so when patients say hip pain, we really ask, like, where in the hip does it hurt? And sacroiliac pain can be referred to the hip joint as well. So that's an important pearl.
Okay. the audience is really shy, or I'm just not getting these questions. So I will plow on. I have another question for our patients. So when you go and you get this diagnosis, how do you cope, or do you cope with receiving a diagnosis of a chronic arthritic condition? How did you process this, and how did you adjust?
Yeah, so
Kind of
well,
vague question, but go ahead.
yeah, so well, first off, like, so definitely it was like a big change in my life. I don't like obviously we didn't expect it, but like I think at first it was just like, oh well, am I gonna have to live with this disease that my entire life, the rest of my life, taking medication and all of this stuff. And so that was pretty scary. But like after a while, like the rheumatologists were definitely very helpful. They like broke everything down for me. They helped me understand, and like now it's just very simple. Like, you know, I just take my anti-TNF agent every other week and also take methotrexate. And basically, it's very simple. Like, it's not something ongoing anymore. I barely notice that I have no pain anymore at all. So it's like, it's not like I can keep up with other kids, you know. It's not like I had to live the rest of my life basically like behind all the other kids because of the disease. So yeah.
Okay, Amina,
I'm
anything to
always
add?
so happy to hear that story, Asad. I think for me, it's a bit of the same. It was already a while ago, of course, that I was diagnosed. And yeah, you get used to the idea and you get your things on how to cope with it. And then over the years, I think you're really, like Asad is saying, it's really okay to deal with it, with things.
Okay. Amina, did you want to add anything? You know, how you might have actually had more of an adjustment than your kid in some ways because Assad was so young.
Yeah, it is obviously when he was so young to be diagnosed, it was daunting initially. However, when we realized there was a treatment plan and actually knowing, I think the hardest part was not knowing. So once we, discovered what it was, we felt some relief knowing that, okay, there's a certain protocol and there are options to treatment. So yes, it was, a lot initially to take in, but knowing that there's steps we can take and to help limit and control, his pain and make him more comfortable, just put us as ease overall.
So there's another question from the audience. Does season affect soreness or stiffness? I guess we can hear from the patients more directly about their experiences. Do you find that with cold or damp that it affects how you feel?
Well, for me, I didn't find like any correlation between the season or the type of weather to my pain at all. So I think it depends on the person, but for me specifically, it wasn't, there was no correlation.
Yeah, for me neither, but I actually know that there are a lot of patients who are experiencing this. So I think it's just really a personal thing, but I think some patients really are experiencing the difference in seasons.
Okay. All right. This may be a little bit outside of the topic, but I know patients will come across it, especially with today's treatment climate. Biosimilars. So, patients may be prescribed a certain medication, but then their insurance company says, you're going to take this. For instance, my physician prescribed infliximab, but then when I went to the day treatment center, I got Inflectra or Renflexis. What's the deal here? Is it okay? Dr. Srinivasalu, might be a good educational point for people so they know.
Thank you for that question. So unfortunately, most of the treatment is mandated by what the insurance covers. And for many insurances, biosimilar is less expensive than a biologic, so to speak. And if the patient is being newly started on a biologic, and if the insurance says biosimilar is what they're going to cover, we oftentimes in clinical practice go ahead and start the biosimilar. However, if the patient has been consistently taking a biologic and has been responding to it, then there is a small chance that they could flare with a biosimilar, although not always. I have had a number of patients who have had the switch from a biologic to a biosimilar, and they have had continued response versus some who may not respond. So it really is patient specific. There is no blanket statement that I can give, unfortunately. However, in your particular case, if there has been a biologic that has been working and you have been switched to a biosimilar because of an insurance mandate and you feel personally that your disease is not well controlled, please bring it up to your physician. Maybe they can do like a peer-to-peer review with their insurance company to reverse their decision. But biosimilars are here to stay, is what I'm going to say.
And I'd also like to add that physicians are your advocates, along with the parents of the patients. Okay. Any last parting bits of wisdom that you've gained? This is for Amina, Asad, and Wendy. You know, as we were talking through this, and you're hearing the various talks. Any last little bits of wisdom that you want to share with the audience, or insights that we didn't talk about in your pre-record that you just really feel like you want to share?
Well, just the whole idea of like being diagnosed is very like, frightening at first, but just with the help of your doctors, you'll be like, yeah, okay, 100%. So just don't give up, stay positive, and yeah, you'll be just fine. Yeah.
And I think what really helped for me was also getting in contact with other people that are experiencing the same thing. I think that really helped my experience, and I would really recommend that to anyone.
Okay. Amina, any last bits to offer?
Yep, just like everyone said, stay positive and follow your treatment plan, whatever your doctor may. Everyone's journey is different, everyone's struggles, pains, everything is different. But I think if you go along with whatever your physician has, the treatment that they have ordered for you, hope for the best, and things there, we hope that everything will be okay.
And then Dr. Srinivasulu, any last parting thoughts?
Sure. I would like to end by saying that this disease should not define you. You are so much more than this disease, and you can be whatever that you want to be. Just look at Wendy. She's a PhD student, and she's been able to navigate life, and she's such a ray of hope to all patients and families. So please stay positive and just take it in your stride.
That seems to be a very good note to end on. So I'd like to make a few announcements. So this material will be released in podcast form. There's a patient podcast that's going to be released July 19th, and a clinician podcast that will be released July 21st. We will also be having more of these educational modules in September. We will be focusing on pain and fatigue in spondyloarthritis and psoriatic arthritis. In October, spondyloarthritis and psoriatic arthritis treatment guidelines, so treatment updates. And then we will be finishing the series in November with a module on does changing behaviors help your arthritis, lifestyle, myths, and solutions. So I'd like to thank Pfizer for making this all possible, and thank our gracious speakers for their time. And then thank you all for attending today's program.